Welcome back to this session where we look at drugs acting in various body systems. Here we're going to look at drugs acting in the peripheral nervous system, where we will first of all review that nervous system and the neurotransmitters that are involved, and then we'll look at the antimuscarinic drugs, adrenergic drugs and anti-adrenergic drugs, and then some drugs that work at the neuromuscular junction, and drugs that have their target as the enzyme acetylcholinesterase. So first of all, the nervous system, as you would know, divided into two major divisions, the central nervous system and the peripheral nervous system, where the central nervous system is further divided into the brain and spinal cord. The peripheral nervous system has two major arms, the somatic nervous system and the autonomic nervous system. In the autonomic nervous system, there is the parasympathetic nervous system and the parasympathetic nervous system. And all of these nervous systems, sympathetic, parasympathetic and somatic nervous system, under the control of the CNS. And then independent of the CNS, the enteric nervous system, which as you can see from this flow chart, is classified with the autonomic nervous system. The autonomic nervous system is principally involved in regulating your viscera, the organs such as heart, blood vessels, digestive organs, kidney and reproductive organs, where it maintains an optimal internal environment, that mechanism called homeostasis. The autonomic nervous system could not function independently of the CNS. It was under the control of the CNS, but it is not under your conscious control. You do not consciously control the regulation of your heartbeat. Your heart will beat whether you are asleep, unwell, under an anesthetic, or quite active, alert and ambulatory. But you can, using holistic healing methods, using meditation, you can learn to regulate autonomic nervous system outflows, and you can, with some training, reduce your heart rate, but your heart would continue beating, we're saying, whether you were consciously controlling it or not. So let's have a look at the roles of the parasympathetic, sympathetic and enteric nervous systems. Go back and review a diagram similar to this of the physiology, the organs that each nervous system affects. Here on the left of the diagram, we show some of the tissues that the parasympathetic nervous system innervates. You'll notice that in common they all have that they are either smooth muscle containing tissues, except for the heart of course, which is cardiac muscle, or they have glandular tissue. So the parasympathetic nervous system principally involved in conserving your body's energy, restoring the body and maintaining its resources, so reducing the heart rate, increasing gastrointestinal activity, normal daily functioning. Whereas on the other hand, the sympathetic nervous system tends to oppose the parasympathetic nervous system. You'll see it operates in many of the same tissues as the parasympathetic nervous system and tends to act oppositely there. In addition, the sympathetic nervous system works on the adrenal glands. It will then increase the release of the hormone adrenaline. But in opposing the parasympathetic nervous system, what the sympathetic nervous system is principally doing is trying to dominate the body in times of stress and emergency to produce a fight or flight response. Anything that will aid in that person either running away from that stressful situation or standing their ground and fighting it. So there'll be an increase in blood sugar made available for the energetic actions that are about to follow. It will increase heart rate to deliver more of that blood sugar to the tissues and more oxygen. It will increase blood pressure to increase the supply of blood to those tissues. The enteric nervous system, as we said, can function completely independently of the CNS, whereas the parasympathetic and sympathetic nervous systems cannot. The CNS controls outflows through those other two arms of the autonomic nervous system. The enteric nervous system, though, independently can control gastrointestinal motility, secretions, or microcirculation. The neurotransmitters in the autonomic nervous system are many. We're going to principally be interested in acetylcholine, abbreviated to ACH, and noradrenaline, abbreviated to NA. Adrenaline is principally a hormone, but it will act at the same receptors as the neurotransmitter noradrenaline. We're going to see a relationship between noradrenaline and dopamine. There are other neurotransmitters, 5-hydroxytryptamine, otherwise known as serotonin, histamine, and so on, many other neurotransmitters. Some of them have neuromodulatory action, such as substance P. Then we have our endogenous opiates, the endorphins and enkephalins, which are neurotransmitters that control pain perception. But as we said, we're going to principally in this session be involved at drugs that act at receptors for acetylcholine, ACH, and noradrenaline in the autonomic nervous system. So acetylcholine, first of all. The receptors that use acetylcholine as the neurotransmitter can be found at various places in the autonomic nervous system. They can occur preganglionically, and this will be in both the peripheral, the parasympathetic nervous system and the sympathetic nervous system. It could be postganglionic in the parasympathetic nerve fibers, and in the sympathetic nervous system, once again, postganglionic, where acetylcholine innervates sweat production during a fight or flight response. Acetylcholine is the principal neurotransmitter in the parasympathetic nervous system, that nervous system that conserves body energy and restores body function, maintains the day-to-day. Acetylcholine activates two types of receptors, and we're going to look at both in this session on drugs acting on the peripheral nervous system. But first of all, we're going to look at those that act at muscarinic receptors, and then we'll later go on and look at the neuromuscular junction and those that act at nicotinic receptors. So you can see there that muscarinic type acetylcholine receptors are further divided into M1, M2, or M3 receptors, where M1 tend to be found mostly in neural tissue, M2 in cardiac tissue, and remember we talked about the ganglion, which you'll see in some diagrams and in your review of the anatomy and physiology, is a collection of cell bodies of neurons. Well, if they occur presynaptically, that also tends to be that M2 muscarinic receptor if acetylcholine is the neurotransmitter there, and if it's in glandular or smooth muscle tissue, that tends to be the M3 type receptor. So you can see that acetylcholine, very ubiquitous as a neurotransmitter in nerves, presynaptically at the ganglion, cardiac muscle, glandular and smooth muscle, found throughout the body. But in addition, there's this other type of receptor, the nicotinic receptor, subdivided into two types, the capital N, little n for neuronal receptor for acetylcholine, and capital N, little m for muscle, where acetylcholine once again is the neurotransmitter. So before we look at the drugs, let's just do a bit of a review of some of the terminology that we're going to be using. If that nerve fibre releases the neurotransmitter noradrenaline, it will said to be an adrenergic nerve fibre or an adrenergic receptor at the effector organ across the synapse from that nerve fibre. So if it's acted upon by the neurotransmitter noradrenaline, adrenaline, the hormone, will also be sensitive there to a certain extent. So noradrenaline was the neurotransmitter in the sympathetic postganglionic nerves, to innervate a whole range of organs in the body. Adrenaline and noradrenaline, the neurotransmitter, principally involved via that sympathetic nervous system and the receptors at producing fight or flight responses in stressful situations, in emergencies, not the normal day-to-day. We'll see that there are two types of receptors, and then these receptors are then further subtyped. So there are the alpha adrenoreceptors or beta adrenoreceptors, and the alpha further subdivided into alpha 1 receptors and alpha 2 receptors. Beta adrenoreceptors further subtyped into beta 1, beta 2 and beta 3. And we'll look at some of these effects that are produced from the different types of the alpha and beta receptors shortly. So we'll just review nerve transmission, requiring you to go back and review an anatomy and physiology text. So we've shown here that we're talking about the autonomic nervous system, not the somatic nervous system. In the autonomic nervous system, we have a ganglion, a collection of nerve cell bodies outside of the CNS. So here's the CNS, the spinal cord. We've shown the grey matter at the centre of the spinal cord, the anterior and posterior horns. So you'll also see, because we're talking about the autonomic nervous system, that we have an interneuron in the CNS controlling its actions. Right, we have some nerve transmission through a preganglionic fibre, and then postganglionic, after that collection of nerve cell bodies, an actual swelling like a ganglion, we have a postganglionic fibre that goes to the effector organs. Being the autonomic nervous system, this will be smooth muscle, cardiac muscle, or glandular tissue. So in your review, whatever anatomy and physiology textbook you use, or your own pharmacology text, these are the key aspects we want you to review. First of all, that for there to be nerve transmission down these postganglionic parasympathetic nerve fibres, we have to make the neurotransmitter. So review biosynthesis. Because it's a cholinergic fibre, we've got to manufacture acetylcholine. You'll note that the choline is made outside of the nerve terminal and then brought to the nerve, where it is then combined with acetylcholine by the enzyme acetylcholine esterase. So then the next thing we want you to review is that that neurotransmitter has to be stored at that nerve terminal. It'll be stored in little vesicles awaiting an action potential to come down that cholinergic fibre. There will be influx of ions leading to that vesicle fusing with the membrane at the nerve terminal and then releasing that acetylcholine. So go and review that release process. Further, that acetylcholine will then have its actions at the effector organ via a particular receptor. The neurotransmitter goes no further than the membrane of the effector organ because there's a protein-rich or a protein-based shape that literally matches the shape of acetylcholine, but also could match the shape of other drugs, or even if a drug had a different shape, but the same functional groups in the same placement as acetylcholine, it could likewise bind to that receptor. Okay, then you also have to review inactivation of a nerve action. This is done with cholinergic fibres by breaking down the acetylcholine back to choline and acetate, where the choline might then be available for uptake by the blood and carried away to be metabolized, or it might be reused locally. Then to have a look at the adrenergic fibres, where noradrenaline is the neurotransmitter, and the drugs that act here, like noradrenaline, are classified chemically as catecholamines. They all have that amine functional group. We're going to see shortly that the catecholamines, noradrenaline and adrenaline, are metabolically related to dopamine. They not only look like dopamine, dopamine is a precursor for them. Dopamine itself is involved in neurotransmission in the brain, where in certain diseases such as Parkinson's or schizophrenia, this neurotransmitter dopamine is in imbalance in the CNS. So here is a diagram of adrenergic transmission. Once again, we want you to go back to an anatomy and physiology textbook and review this. We want a good visual picture of this action so that you can visualize where and how the drugs are working, and it will make it a lot easier to work out their actions and effects and their contraindications and adverse effects. So similarly, the features we want you to review are, first of all, that for there to be an action at this adrenergic fibre, which is post-ganglionic, after the ganglion, after the collection of nerve cell bodies outside of the CNS, in this sympathetic nervous system, you've first of all got to manufacture the adrenaline. So as shown here, dopamine, a precursor made from the amino acid tyrosine, which comes in from outside, from the blood, but it's in the nerve terminal itself that dopamine is first made, and then noradrenaline. Where the noradrenaline will then be stored, review that as well, and then the release only when an action potential comes down the nerve fibre. There are ion channel changes that lead to that vesicle fusing with the nerve terminal membrane, then releasing that noradrenaline to once again cross a synaptic cleft, a little space, and act on the affected tissue. There will be a receptor, a protein-based shape with just the right shape for noradrenaline, but there are two different types of protein receptor. They could be alpha or beta type. So furthermore to adrenergic transmission, you have to review several aspects of inactivating the neurotransmitter noradrenaline via two enzymes, COMT and monoamine oxidase, where it is broken then down to metabolites, taken in the bloodstream and maybe used by other tissues of the body or taken back to that nerve to be reused. But there is one other aspect unique to adrenergic transmission, where that noradrenaline, if not broken down, might then be taken back up again by the presynaptic nerve. So this is termed that reuptake process, shown here where some of the noradrenaline might be stored in a vesicle for some more release. So we're going to see some drugs that affect that reuptake by either blocking or enhancing that reuptake of noradrenaline. So then the adrenergic receptors, first of all the alpha type. There is alpha 1 and alpha 2 receptors. They have different effects and sometimes they can have opposing effects, so long as you can remember that. But the other key difference between alpha 1 and alpha 2 receptors tend to be located presynaptically, before the synapse, on the nerve terminal, but once again only rich in certain tissues. The alpha 1 receptors tended to be postsynaptic. They tended to be on the effector organ after the synapse. So alpha 1 receptors, when they are stimulated, tended to lead to vasoconstriction of peripheral blood vessels. This will raise blood pressure. They tend to mediate the dilation of the pupil. This will be contraction of the iris muscle, but that mydriasis, the wider pupil. Alpha 1 receptors will also increase the contractility of the heart and inotropic effect, but once again it does depend upon how many alpha 1 receptors there are in the heart, and we'll see there is a more predominant receptor there, but that term an inotropic effect. They'll improve the contractility of the heart via that alpha-1 receptor. So the alpha-2 receptor, the one that tended to be located presynaptically, rich in tissues such as liver, it's also found in platelets, and blood vessel smooth muscle, where stimulation of this receptor tends to lead to inhibition of transmitter release. So if transmitter would normally lead to increased blood pressure, then this will oppose that at an alpha-2 receptor. So you begin to see why I said alpha-1 and alpha-2 can often oppose each other. But alpha-2 also has some unique actions. It will aggregate platelets and will lead to the contraction of smooth muscle. The beta receptors, once again, it does depend upon their predominant numbers in a tissue, and beta-1 receptors are the ones that are quite rich in the heart. So adrenaline would normally have effects on the heart via the beta-1 receptors simply because there's more of them in the heart, where it will lead to increased heart rate and increased contractility. So at alpha-1 receptors we saw that increased contractility as well, an inotropic effect, but beta receptors also have an added effect on the heart, that chronotropic effect, which was the increased heart rate. Beta-2 receptors tended to be rich in smooth muscle, particularly in the bronchioles, blood vessels, and other visceral organs, where stimulation here at beta-2 receptors caused relaxation of the uterus, affects metabolism, increasing the breakdown of glycogen by glycogenolysis, that metabolic pathway, and leads to the dilation of bronchial smooth muscle. You'll recognise these beta-2 actions as being very important in that fight or flight response, along with the beta-1 actions. Now, beta-3 receptors are different, and we won't talk about them too much. They are localised to adipose tissue, but we still ask you to review them when you go back to your anatomy and physiology text. So we said with adrenergic fibres, it does depend upon which type of receptor is predominant in that tissue, and we're also going to see that it depends upon the concentration of the exogenous drug. When looking though at noradrenaline and adrenaline as endogenous substances, some of the differences that are noted are these. Noradrenaline tends to mainly excite alpha receptors. It does excite beta receptors to a slight extent as well. It is the neurotransmitter in the heart at those beta receptors, the beta-1. But it's adrenaline, the hormone, in those fight or flight situations that principally excites alpha and beta receptors, where it excites both of them equally. So we're looking there at the efficacy of the endogenous substance for that receptor. So keep in mind that some of the drugs and their adverse effects are quite complex and become dose dependent. It does depend upon the exogenous receptors, on the relative number of alpha and beta receptors in that particular organ. And we'll see that in the pregnant female in the uterus, it depends upon lifespan changes. Towards the end of the pregnancy, there is a change in the number of receptors on smooth muscle uterine tissue. But in general terms, the heart principally contains the beta-1 receptors, mostly affected by adrenaline, slight effects of noradrenaline, slight but important effects physiologically. So now we'll look at adrenergic and cholinergic drugs. First of all, cholinergic drugs. So these are agonists that are working at cholinergic receptors, or they could be antagonists, blocking at those cholinergic receptors. Drugs that block at the muscarinic receptor will be referred to as muscarinic drugs, but also in general just called anticholinergic drugs, because they are blocking acetylcholine and its ability to bind to that muscarinic receptor. By binding to the receptor, that drug will cause acetylcholine to fail. It will no longer produce its cholinergic effect. So we're principally interested at these drugs acting in the parasympathetic nervous system, where acetylcholine is the main neurotransmitter. So these drugs might also be termed anti-parasympathetic because they'll produce an anti-parasympathetic response, or they might also be termed parasympatholytic, breaking the actions of the parasympathetic nervous system. So cholinergic action, by contrast, will increase that parasympathetic response, and we'll see these are termed parasympathomimetics. A mimetic drug, one that mimics the action of acetylcholine in the parasympathetic nervous system, will act at that muscarinic receptor as an agonist and produce the same effect as acetylcholine at that parasympathetic nerve terminal. So it will be a parasympathomimetic drug. A lot of letters in that term, a lot of syllables, but I want you to break it down like this. First of all, the nervous system that's involved, go all the way through to that syllable there, parasympatho. And then the fact that they are mimetic at that nervous system, they're mimicking it, parasympathomimetic. So we're interested in 3 drugs, one used in the urinary bladder and in the gastrointestinal tract, and 2 used in glaucoma in the eye. So bethanechol, used systemically for urinary symptoms and gastrointestinal symptoms, where it will promote micturition or will improve gastric motility. Then the 2 that are used not systemically but topically as eye drops in the eye at that iris to improve the amount of aqueous humour that can flow into the trabecular meshwork down through that canal of Schlemm and be filtered away and recycled. The person has raised intraocular pressure because of all the build-up of that aqueous humour, and that's what's causing the symptoms of their glaucoma, and the eye drops will relieve all of that intraocular pressure and help with the outflow. Similarly, pilocarpine, but it's only used as eye drops topically, whereas the carbachol is available as an intraocular injection to dramatically drop the intraocular pressure in a person with glaucoma. So those were drugs that were cholinergic. Now we'll have a look at those that are anticholinergic, and more specifically antimuscarinic. At that muscarinic receptor is where they're having their blocking action. So the 2 drugs we're principally interested in are atropine and hyoscine. Interesting also that they have a similar drug lead history. They came from pharmacognosy, the study of natural substances. And atropine was extracted from Atropa belladonna, which is deadly nightshade plant, and hyoscine was extracted from Hyoscyamus niger or henbane, from which it got its name, but is also in high amounts in Jimson weed, Datura stramonium. Atropine, first of all, then, as the drug, we talk about it as being the classic muscarinic antagonist. It's the prototype for the drug class. This drug has very little action on those nicotinic receptors. So it was one of the natural substances that was first used to subdivide the nervous system. As a drug, then, it's been used for decades, many more than 50 years. And we'll talk about some other anticholinergic drugs. They may be acting as antidepressants and may be having their pharmacodynamic action in other ways, but they produce adverse effects because they are anticholinergic. So we're going to refer to these adverse effects as the atropine-like effects, atropine being the prototype. So before we study those adverse effects, let's have a look at some of the body tissues where acetylcholine is the neurotransmitter and atropine is blocking its actions. You'll begin to see what I said by acetylcholine is ubiquitous, widespread. The parasympathetic nervous system controlling many unconscious and autonomic effects. So first of all, in the eye, if you can remember that acetylcholine causes meiosis, pupil constriction. So atropine, being a blocking drug, will do the opposite. It will produce mydriasis, or pupil dilation. The other way to remember that for atropine, it was extracted from Atropa belladonna. Belladonna means beautiful lady. Women were deemed more beautiful if they had a dilated pupil. And the same is true of photos of human faces. If photos are drawn with a more dilated pupil, for reasons that the person cannot consciously specify, they're just aware that they think that picture looks more attractive to them. The dilated pupil being one of those signals that the brain is very receptive to. So the belladonna, beautiful lady, has the dilated pupil. Atropine from Atropa belladonna produces that dilated pupil. Atropine will inhibit secretions. So, for example, you'll get a very dry mouth with atropine. But more on that later when we talk about the classic atropine-like adverse effects. In the respiratory system, atropine will relax the muscles of the bronchial tract. The effects that it has in the heart on muscarinic receptors and in the gastrointestinal tract, once again at those muscarinic receptors, is actually dose dependent. We're going to see that a lot in the adrenergic system, but here there is a bit of complexity to the cholinergic system, where it is a dose-dependent effect in the heart. Atropine can actually decrease the heart rate at low doses, whereas in high doses it will inhibit gastrointestinal motility, a normal cholinergic blocking action. So acetylcholine would normally raise gastrointestinal motility, and atropine, being antimuscarinic, will block that. In the urinary tract, atropine will relax smooth muscle, but the sphincters will be constricted. In the CNS, though atropine does not cross the blood-brain barrier in large amounts, in certain people it can produce idiosyncratic responses of excitement and mania. So think of these women using Atropa belladonna plant and using it in the eye. Some CNS, some systemic absorption first of all, and some CNS adverse effects, some mania and excitement. Now, hyoscine is designed to cross the blood-brain barrier. It's like atropine, blocking muscarinic receptors, where it is an antagonist, simply because it is similar in chemical structure to atropine. So it has similar peripheral effects to atropine. Being absorbed in higher amounts through that blood-brain barrier, though, it is indicated for motion sickness, where in the CNS it blocks nausea and vomiting at the chemoreceptor trigger zone or other sites in the CNS. So because of this, it's used as an adjunct in general anesthesia, where as an added advantage, it reduced secretions. So in the respiratory tract, this is a good thing. The person is less likely to inhale their own saliva. If there are reduced secretions, even in the respiratory tract, less mucus, less likelihood of adverse effects following general anesthesia. If there was less mucus production, less of it to then travel down into the parenchymal tissue of the lungs. However, because hyoscine does cross the blood-brain barrier, has a few extra adverse effects to atropine, where it causes drowsiness, euphoria, memory loss, relaxation, affects sleep, produces a feeling of relief from fear or relief from depression. It does not, in the periphery, increase blood pressure or respiration, and it doesn't produce that effect in the CNS either. But those classic anticholinergic adverse effects of drugs that act like atropine, and here we're including a wide range of drugs for other indications, so antihistamines and tricyclic and tetracyclic antidepressants. All of these have adverse effects in the CNS similar to atropine, or in the periphery of the body similar to atropine. So here's all of the effects. You have to know them all. For some of them, once again, we're suggesting go to your anatomy and physiology textbook and look up why that is logical. So for example, we said acetylcholine leads to meiosis and a constricted pupil. So drugs that block its actions will cause mydriasis, the expanded pupil, but this will blur vision. So the other classic atropine adverse effects, tachycardia, heart palpitations, decreased bronchial secretions, that could sometimes be a problem, antispasmodic effects on smooth muscle, but that dry mouth. It's not so much with atropine, because after surgery that dry mouth feeling is temporary, but if a person is on antihistamines or tricyclic antidepressants and using that drug long term, this will be a chronic adverse effect type C from chronic use of the drug. But in addition, there can be urinary retention and male impotence, classic reasons why people might stop taking their medications. Very important for a person with depression to keep taking their medication, but if they're getting too many bladder infections, or for men, it's causing them impotence, they'll sometimes choose to stop taking it. Once again, we asked you to go and review the Anat and Phys. Here we have acetylcholine, which would normally raise gastrointestinal motility, improving it. But a drug like atropine that will block the actions of acetylcholine will decrease gut motility. This will lead to constipation. So it might also lead to people stopping their medication if it's something like an antihistamine or a tricyclic antidepressant. Or it may require them to see a natural therapist to get some help for that constipation, or they might take Western pharmaceutical, over-the-counter meds and so on. And then the classic adverse effect of atropine in the CNS is dizziness. Remember, hyoscine has more CNS adverse effects because more of it crosses the blood-brain barrier. So because of these other effects, there might be certain situations where an anticholinergic drug is contraindicated, abbreviated to C/I. We'll also look at some drug-drug interactions that can be explained by the effects of that anticholinergic drugs, either pharmacodynamic effects or perhaps pharmacokinetic effects. So with tricyclic antidepressants and antihistamines, because they're working in the CNS in the same way as anticholinergics, they will have an additive effect, a drug-drug interaction that is pharmacodynamic. Because anticholinergic drugs reduce gastrointestinal motility, if there's another drug that relies upon the gastrointestinal tract for its absorption, then there'll be less of that drug that is absorbed. So there'll be a drug-drug interaction between that drug and the drug that has these anticholinergic adverse effects. So that's a pharmacokinetic interaction between two drugs. So then, quite reasonably, there are some situations where an anticholinergic would be contraindicated. We do not want to block the actions of acetylcholine in a disease state called myasthenia gravis. And I want you to go back and review it. You have done some of the pathology of autoimmune diseases. Look at the one that affects the neuromuscular junction, this myasthenia gravis, where an anticholinergic drug would be contraindicated in its use. Similarly, if a person had severe cardiac disease or had an existing gastrointestinal obstruction, you would not take a drug that further reduced gastrointestinal motility. If a person has a narrow angle glaucoma, an anticholinergic would be contraindicated. People who have Down syndrome have problems with their heart, but an anticholinergic would be used with caution in these people, or perhaps it might be the elderly or those with a hepatic or a renal disease. Similarly, let's look at the adrenergic drugs and those that block the actions of noradrenaline at the neurotransmitter, those that are anti-adrenergic. We're going to look at three different subclasses of drugs that have their actions either at the adrenergic receptor or blocking it. We're first of all going to look at those that are agonists, that act directly, those that have an indirect mode of action, and then those that block. So first of all, the term that we used for those that act directly, they are sympathomimetic drugs. Break it down then. What nervous system is involved? The sympathetic nervous system. And it's miming the actions of that sympathetic nervous system. So miming the actions of noradrenaline, producing the same effect on the organ as the sympathetic nervous system would. So these are drugs that in their mode of action work the same way as particularly adrenaline here at creating a fight or flight response, which includes increased cardiac output, vasoconstriction of arteries, arterioles and veins in certain tissues, regulating body temperature, and in dilating the bronchi. In a fight or flight situation, you want to have better patency of your airways so that you can get better gas exchange of that oxygen and then better cardiac output to move it around the body. Vasoconstriction will raise the blood pressure and so on, a stress response. So these drugs will mimic that response. They are the naturally occurring catecholamines, adrenaline, noradrenaline, and dopamine. So we're going to look at those being used as exogenous drugs. But in addition, we're going to look at some synthetic drugs. So isoprenaline as an example to show you how it quite logically would be chemically similar to adrenaline. Its name, its generic name, was chosen so it sounds similar to adrenaline. It's isoprenaline, and some other synthetic drugs. So once again, it depends where this sympathomimetic drug is acting. Is it acting at alpha receptors or beta receptors? If it was an alpha receptor, this drug similarly would cause vasoconstriction of peripheral blood vessels, leading to raised blood pressure at alpha receptors. It would lead to pupil dilation at that alpha receptor, and it would relax the gut at that alpha receptor. We also said that the sympathetic nervous system tends to oppose the parasympathetic nervous system. So just review the parasympathetic nervous system's actions on the pupil and on the gut, and you can see that the sympathetic nervous system is opposite. The sympathetic nervous system is dilating the pupil and relaxing the gut. And now we're telling you the individual receptor that's doing that, the alpha receptor. But there's this other receptor, the beta receptor. We'll see it depends upon what tissue you're talking about as to which receptor predominates. So the beta receptor and stimulation of it principally leads to increased heart rate and contractility, because there's a lot of these beta receptors in the heart. And we'll talk very shortly about the various subtypes of beta receptors and the one that is more predominant in the heart. But remember those terms: positive chronotropic effect, increased heart rate, and positive enotropic effect, better contractility. And now we're telling you the receptor that mediates that, it's the beta receptor. And more information shortly about which subtype. The beta receptor also causes vasodilation of skeletal muscle arterioles. So as we said, sometimes you've got to learn the complexity. The effects of adrenaline and noradrenaline on blood vessels depend upon which tissue you're talking about and which receptor predominates. So if it's blood vessels in the peripheral circulation, it'll be an alpha receptor, where you're going to get vasoconstriction from that endogenous or exogenous substance. But if it's the blood vessels in the skeletal muscle, you'll get the opposite action. You'll get vasodilation because there's a different receptor present, a beta receptor, which mediates vasodilation. But it is the beta receptor that will mediate bronchial relaxation, and also, once again, depending upon the stage of the pregnancy, and towards the end of a pregnancy, the uterus and the smooth muscle there tends to produce more beta receptors. We'll see the type, or a subtype I should say, is beta 2. That increases in that uterine muscle, and by stimulating those beta 2 receptors, we get relaxation. So a complex picture with the adrenergic receptors, further shown on this diagram of the post-ganglionic sympathetic nerve fibre at its terminal. So remember, post-ganglionic simply referred to the fact that in the autonomic nervous system, there is an interneuron in the CNS, and just outside the CNS, or maybe close to the effector tissue, but generally just outside the spinal cord, there's a ganglion, a collection of nerve cell bodies, and we're looking at the fibre that comes out post-ganglionic. Noradrenaline is the neurotransmitter, so it is in vesicles which fuse with the nerve terminal membrane. It crosses a synaptic cleft, but it now depends upon whether alpha receptors or beta receptors predominate in that tissue as to what effect you have. So we saw that if it was blood vessels in the periphery, at alpha receptors we'd get vasoconstriction. But if it was in arterioles of skeletal muscle, which is richer in beta receptors, we'd get vasodilation. It just depends upon the receptors and their richness. Now there is a further complexity again, provided by the different two types of alpha receptors. Alpha 1 tended to be richer postsynaptically, but presynaptically we have these alpha 2 receptors, and they control any further release of noradrenaline. It's a negative feedback. Where there is already high concentrations of noradrenaline, these alpha 2 receptors mediate responses that prevent any further release of any more noradrenaline. So we're going to see with drugs that act either as adrenergics or antiadrenergics, for some of them it depends upon the dose as to which receptor you are stimulating, whether it's alpha 2 or alpha 1 or one of the beta receptors. So now let's have a look at the drugs. Adrenaline, first of all, as an exogenous drug in certain disease situations, such as a hypersensitivity reaction type 1. First of all, this adrenaline is stimulating at both alpha and beta receptors, whereas we saw it is equally as effective, but it is dose dependent as to what tissue response you see. In the heart principally has beta receptors, particularly as we'll see beta 1. In smooth muscle of the bronchi and blood vessels, we'll also get stimulation of the alpha and beta receptors there. In the heart, stimulation of those beta 1 receptors, which tend to predominate, will cause a positive inotropic effect. It will increase the contraction of those heart muscle cells. We'll also get a positive chronotropic effect. Adrenaline as a drug will increase the heart rate. Now further, by acting at those receptors, adrenaline as a drug produces a dromotropic effect, where this is affecting particularly the cardiac muscle cells at the atrioventricular nodes, where we're getting improved conduction. Adrenaline as a drug at blood vessels has variable effects, and you just have to get used to that. Okay, it does depend upon the dose. So various formulations might have adrenaline in low doses in the drug to cause a lower blood pressure, but generally adrenaline will cause high blood pressure, because usually when given as a drug it's given in high doses, a dose dependent effect. Now once again, adrenaline, designed to cross the blood-brain barrier as an endogenous hormone, so as a drug will show adverse effects, restlessness, tremor and anxiety as it crosses into the CNS. Similarly, the endogenous substance would normally relax smooth muscle but constrict the sphincters. So adrenaline as a drug will do similarly. There will be a delay in the desire to void the urine from the bladder, reduced micturition. Respiratory effects, adrenaline will be a powerful bronchodilator. So one of the reasons why it is given in that type 1 hypersensitivity response and allergic response is because the person's airways have shut down due to histamine and other mediators, and so a drug is given immediately via an EpiPen designed to give a systemic dose of adrenaline quickly to cause bronchodilation. That adrenaline will then have some immediate metabolic effects and some long-term metabolic effects. It's going to immediately increase oxygen consumption. It will make available more fuels to the cells, such as glucose, but it will also increase the breakdown of triglycerides in adipocytes to produce some free fatty acids in the blood. Similarly, adrenaline will affect blood vessels, but remember this depends upon which receptor is abundant in those tissues. In skeletal muscle, it's going to cause a vasodilation, because remember that's a beta receptor effect that drug adrenaline is having. So adrenaline will be indicated for anaphylactic shock, that type 1 hypersensitivity to an allergen, a very severe allergic reaction which shuts down the airways, causes massive drop in blood pressure because of shifting of blood volumes in compartments, or it might be the person has a bleed and that has caused hypovolemia, a low blood volume, a drop in blood pressure. So we may want to use adrenaline in the treatment to prevent that bleeding. For example, in surgery such as ocular surgery, we might want to once again mimic the effects of vasoconstriction in certain tissues, a hemostatic agent to control superficial bleeding. It'll be used in a topical preparation. And then one other major indication of adrenaline, cardiac arrest. So you'll see in the some of the shows on TV where they're looking at emergency departments and their operation, that they will deliver adrenaline directly to the heart in a cardiac arrest to rapidly increase the heart rate. So as a drug, adrenaline will have various adverse drug reactions and will produce various drug-drug interactions. Its adverse drug reactions, those CNS effects, nervousness, insomnia. It may produce a tachycardia, tremors, sweating. It might lead to hypertension as an adverse effect. It might cause nausea and vomiting. High doses could induce ventricular arrhythmias in sensitive people. Because it affects metabolism and has then some other immediate and delayed effects, it is contraindicated in people who have diabetes mellitus or have an existing hypertension, have ischemic heart disease. So we'll see they may have had a myocardial infarct or are at risk of a myocardial infarct, a heart attack, due to an ischemic heart disease. It is contraindicated in people who are hypothyroid and contraindicated in people who have Parkinson's disease. It produces drug interactions with various anesthetics, beta blockers. So here we have a drug that blocks the actions of adrenaline at beta receptors, and here we're giving adrenaline as a drug. Then those two drugs clearly will pharmacodynamically block each other. There are many drugs that interact with digoxin. We have mentioned it before as a cardiac glycoside, acts on the heart, and it will interact with adrenaline. Oxytocics are drugs that, like oxytocin, affect the smooth muscle of the uterus, and adrenaline will interact with those drugs and their effects at beta-2 receptors. Adrenaline will also interact with tricyclic antidepressants, monoamine oxidase inhibitors. At this stage, we've only talked about the enzyme monoamine oxidase, so review your anatomy and physiology textbook about its actions, and then we're going to have a look at some drugs that target this enzyme. But adrenaline will also potentiate, in the presence of cocaine, those cardiac effects and so on. Noradrenaline as a drug will have a higher affinity for alpha receptors than it will for beta receptors. So this will explain its adverse drug picture. It will produce vasoconstriction in the skin and mucous membranes because it's having a greater effect at those alpha-1 receptors. But that, once again, being alpha-1 is a dose-dependent effect. Okay, it also will have effects on the blood vessels leading to the visceral organs, so of the abdominal or chest cavities. Noradrenaline will be used to restore arterial blood pressure in people who have an acute hypotensive state. It will be used as an adjunct in cardiac arrest by IV administration. The adrenaline will be used in emergency, and the noradrenaline will be used to maintain a better heart rate. It has to be given IV because it will be completely inactivated by enzymes in the gut and will be therefore ineffective if administered by any other route than IV. So once you know the physiological picture, it isn't too hard then to remember the adverse reactions. It will cross into the CNS and produce that anxiety, dizziness and tremor, the same as the endogenous adrenaline or exogenous adrenaline will do. So noradrenaline will be contraindicated in people that have atheromas in the major arteries, bringing blood to the tissues of the heart, the coronary arteries. So if a person has that atherosclerosis, noradrenaline will be contraindicated. It is also contraindicated in hypoxia. Isoprenaline, remember, was one of the synthetic substances that is similar to the catecholamines, dopamine, adrenaline and noradrenaline. It tends to be non-selective, so it will act at beta receptors, but it will also have effects at alpha receptors, and it isn't selective for beta 1 or beta 2 receptors. It will be equally as active at both of them. So at beta 1 receptors, it's going to increase the force of contraction, that inotropic effect, but it will also increase the heart rate, that chronotropic effect. At the beta 2 receptors, isoprenaline drug will relax the smooth muscle of the bronchi and improve the patency of the airways, get more oxygen in. The person will be able to breathe better. So it's indicated as a cardiac stimulant, an adjunct in a person who has a septic shock or some sort of hypovolemic state. Might be just bleeding that has led to hypovolemia. Its adverse reactions will be exactly the same as adrenaline, it's just a synthetic form of it. So it is used with caution, similarly to adrenaline, in the elderly. It, like adrenaline, will lead to immediate and delayed effects on metabolism, so used with caution in diabetics and those with hypothyroidism. So whereas it might have been a drug that was contraindicated in those people, we now have one where we can use it but with caution. However, isoprenaline will still be contraindicated in a person who has tachycardia or a myocardial infarct, that heart attack. We said dopamine, another catecholamine, physiologically was a precursor to adrenaline and noradrenaline, but it is also a neurotransmitter. Dopamine as a drug will be acting on those dopamine receptors, but will also be having effects on beta 1 receptors in the heart, and in high doses, dopamine will affect alpha 1 and alpha 2 receptors as well. So once again, a dose-dependent effect there, and the actions of dopamine quite complex. But at low to moderate doses, dopamine is given to have effects on beta 1 receptors of the heart to stimulate it, similarly to noradrenaline. So increased heart rate, that chronotropic effect, giving a greater stroke volume, a better cardiac output, which is abbreviated to CO. So dopamine will be indicated in people where there is circulatory shock. It might also be used in people with congestive heart failure. So now that you know the adverse effects of adrenaline and noradrenaline when used as drugs, compare that to dopamine. But remember that there's also these extra dopamine receptors in the brain. Dopamine will lead to headaches, nausea and vomiting. In the periphery, it will lead to angina, a drop in blood pressure, which might be excessive hypotension, but less frequently it could cause hypertension because of effects on other adrenoreceptors. So in summary, we've looked at drugs that act directly by mimicking the effects of the natural neurotransmitter noradrenaline in the sympathetic nervous system. But it wasn't that easy. We said that noradrenaline actually has less effect at beta receptors than adrenaline, the natural hormone. But the agonists, the drugs that were sympathomimetic, acted at alpha-1, alpha-2, beta-1, or beta-2 receptors, and so their effects tended to be dose-dependent as to which receptor they were affecting, and also depending on the distribution of those receptors in the particular tissue. Adverse effects were explained by the fact that these sympathomimetic drugs tend to be non-selective, affecting the different receptors and subtypes and affecting them differently at different doses. Adrenaline was one such drug that showed dose-related effects. It was indicated for asthma, for local hemostasis, used in a topical solution, perhaps in dentistry to stop bleeding, but its main use in acute anaphylactic shock. For example, those people who are allergic to peanuts, they'll carry an EpiPen for immediate treatment of that acute anaphylaxis. The shutting down of the airways and the drop in blood pressure, the hypotension, and it will block both of those actions of the allergen that's causing that shock. But adrenaline will also be used in open angle glaucoma and cardiac arrest. The synthetic drug was isoprenaline. Noradrenaline, also like adrenaline, had dose-dependent effects on the blood vessels in the kidneys and other visceral organs. It tended to work at alpha receptors, but that was dose-dependent. It tended to be just at the higher doses, where noradrenaline would be used in cases of shock. Dopamine, once again, as a drug, precursor of adrenaline and noradrenaline, so can be used as a sympathomimetic, but produces dose-related effects. Adverse effects on dopamine receptors, but some of its pharmacodynamic effects on those dopamine receptors, but it will have direct and indirect effects on beta receptors, particularly beta-1, but at high doses affected alpha-1 and alpha-2 receptors, where it has its major indication in treating circulatory shock and congestive heart failure or congestive cardiac failure.